Good afternoon, everyone. This is Gail Donovan with the Scottsdale Institute. Thanks so much for joining our webinar this afternoon. We are really pleased to bring this topic to you, which is impactful for many different reasons, both the content of what we're going to hear about, but also helping to address burnout and other workforce issues. I want to take a moment and just go over a couple of housekeeping items. You all are placed off camera and muted, but we will encourage you to participate in our Q&A. We'll have time at the end of our session today. And please enter your questions for Dr. Linz in the Q&A tab located at the bottom of your Zoom screen. We do record our session, and the recording along with the slides will be posted by Decretia moments after we finish our webinar today. We also will be asking you to complete a very brief survey. It will take 1 minute, we promise, of your time. And it does help inform us to look at our content going forward for additional events that the Scottsdale Institute will host. So today's webinar, as you see here, is titled Introducing Meaningful Patient-First Medication Guidance, while at the same time tackling alert overload. And we're pleased to have with us Dr. David Linz, who is the Chief Medical Informatics Officer for a health system called NCH, which is located in Naples, Florida. And he'll explain a little bit about NCH as he moves into the presentation. But NCH had the opportunity to collaborate with a vendor called First Data Bank to tailor medication alerts specifically to patient context. So this focus on patient-first medication decision support has resulted in marked reduction in frequently dismissed alerts for conditions such as hyperkalemia, QT prolongation, opioid use in outpatient settings, and other conditions. So Dr. Linz is going to explain the journey they've been on, what results they've been achieving, and we're looking forward to his presentation today. Dr. Linz, thanks so much for joining us. I'm going to turn this over to you now so we can get underway. Thanks again, everyone. Enjoy the webinar.
Thanks so much, Gail, and thank you all for joining, either live or on the recording. I hope to make this a useful experience. So without further ado, I'm going to try to advance my slides.
So you came out of presentation mode, David. So
I did, because it's not advancing. My apologies here.
So why don't we have Decretia advance your slides, and when you're ready for the next slide, why don't you please let her know to please advance.
Thank you. Yeah, Decretia, if you can advance as soon as you can take over. So as you introduced myself, I am our system's Chief Medical Informatics Officer, but I also practice internal medicine, so outpatient primary care. So I really live this every day, and I've really felt personally in my clinical practice the significance of the changes that we've made. I'm just going to put the screen in front of me. If you would go to the next slide, please. So the agenda in this hour is I'm going to give you an introduction to the EHR's impact on healthcare provider burnout. We're going to discuss the impact of alerts on provider satisfaction and patient safety. And then we're going to review strategies to improve the medication alerts. Next slide. So the key things that I hope you can walk away from today is the ability to analyze the impact of generalized clinical alerts on clinician burnout and identify strategies to optimize the medication alerts using patient-specific data. And we're going to go into what that data is. I hope you can develop a collaborative approach with the pharmacy team to evaluate and improve the relevance of medication alerts in your electronic health record, and be able to implement proactive measures to mitigate alert fatigue and enhance both the clinician wellness and the patient safety in this fast-paced clinical setting. Next slide. So NCH, our acronym stands for Naples Comprehensive Health, and we're an advanced community healthcare system. So we're an independent, not-for-profit healthcare system that comprises 2 hospitals in Southwest Florida. And we like to say that we take care of Naples and beyond. We do this, we're more than just a community health community hospital because we have a robust GME program. We partner with Mayo Clinic College of Medicine and Science. We have a partnership with Hospital for Special Surgery as we develop our orthopedics program, and we have industry-sponsored research at our hospital. So one of our goals really is to stay independent, and we have several aims to do that. And this kind of goes into it, is to prevent physician burnout, develop resiliency, to attract and retain top talent, and to produce high quality care. Next slide. So I hope that I don't have to do a lot of convincing that burnout is real. It's ever present in the industry. It's not just physicians. It is pharmacists, nurses, all clinicians really. EHR is a significant source of that burnout, and now EHRs are nearly ubiquitous. What I want to impart is that it's easier to prevent burnout by increasing EHR efficiency than it is to try to reduce burnout after it's peaked. We know that burnout can lead to lower quality and higher costs in healthcare. So it's definitely at the forefront of our institution, and I imagine it's the forefront of yours as well. Next slide. So we're going to focus on just one piece of this problem. Here I have listed many of the main causes that have led to physician burnout. And we have at our institution projects in all of these domains, but we're really going to focus on the alert fatigue. And again, this is just EHR's impact on burnout, but the other 2 of the top 3 most cited etiologies of burnout is also staffing shortages and pressure, and then lack of alignment from leadership. So let's try to just delve into this alert fatigue here today. So what I wanted to share with you is that we've polled our clinicians with an AMA burnout survey. These are the results from our initial survey 2 years ago, but we just completed a follow-up survey 2 years later, and unfortunately, there hasn't been a significant change where about half of our providers are noting that they have significant frustration of in their day that is due to the EHR. But I think that one of the things that I really want to dive into is that only a small portion of the variation in EHR experience is explainable by the EHR itself. More than 50% of the variation can be explained at the physician user level. So what I'm trying to say is provider organizations seeking to create a positive user experience cannot expect the usability of software alone to create a consistent physician user success. Instead, factors unique to the individual physician users must be identified to reduce that negative variation. So looking at things like alerts is really important to have a better user experience, to reduce that frustration, promote wellness, reduce burnout. Next slide. So the project that I'm going to talk to you about really started in 2000 when we did a very thorough evaluation of our current EHR. And we knew that the platform that we were using wasn't sufficient for the quality of care that we wanted to deliver. And it was very frustrating to use from a clinician standpoint. So we knew that we wanted a significant optimization project. And so we did an evaluation whether we were going to convert to a new system or whether we really needed a whole new instance of our existing EHR. Because one of our main issues is that we had customized the environment so much so that it was very difficult to maintain. And every time we would take an upgrade, we would take one step forward and several steps backwards because a lot of things wouldn't work. And for that reason, we would go many months in between upgrades, and we were really behind the curve of all the useful things in the EHR that could be provided that we weren't using. So we ultimately decided that a conversion was necessary. And we spent 18 months in in phases of planning, building, and we went live just over 2 years ago now in June of 2022. That was an eye-opening experience, really in team building, and I'm going to go through some of the strategies that we used there. We then went through a phase of optimization. Once the system had been live, we realized a lot of things that were working really well, but it helped us identify the things that we wanted to make further improvements on. And now we're in an ongoing optimization stage. We've developed a clinical decision support team, and I'm going to talk to you about how we engage that team to maintain the system and optimize the system. Next slide. Great, thanks. So I wanted to point out a couple of the key elements in our transition. So two of, I think, the most important goals and objectives were to increase physician and clinician satisfaction. That was very much at the forefront of our mind, but ultimately it came down to patient experience and care, and we really wanted to improve that quality of care. So those were two of the biggest objectives in our project. We also had several guiding principles, and we would review these guiding principles at all of our meetings when we were in the planning phase. And I think it's important to highlight a couple of those here because you'll see some of the themes pop up. But this was a clinical and a financial transformation project that was enabled by IT innovation. We tried as much as possible to not be an IT-led project. We really wanted to be IT-enabled. And looking at all those clinical and financial decisions to make each step better. We also wanted to look for native EHR solutions first, and that was really for ease of use and ease of maintenance. And we wanted this to be a strong transformation structure to enable that established or that included physicians, clinicians, ancillary, and operational leaders. So all the decision making during this conversion was made as a team, and we've used some of that team structure in our optimization and maintenance phases. Next slide, please. So in our legacy system, specifically as it related to clinical decision support, we had such a difficult time in our system, in that highly customized system, that the alerting was a real problem for us. And it was so much of a problem to the clinicians that we really had to turn off all but critical medication alerts to the providers. However, all the alerts were still going to the pharmacists. So the pharmacy was the only clinician receiving the medication warnings other than those critical alerts. And they had a significant amount of alerts, and a lot of that burden was placed on them. So it really wasn't a sufficient team-based strategy there. So the aim of this project was to reduce the clinician burnout, both physicians as well as pharmacists and nurses. We wanted to improve patient safety, and we really wanted to maximize the efficiency of this alerting by leveraging information of our EHR. We wanted the EHR to be the source of truth, and we wanted it to be populated with useful information, information to include medications, labs, and problems to make that alerting as beneficial as possible. And then we really wanted, we wanted a smooth transition. I mean, again, we're going from a legacy system where physicians were receiving very few alerts, and we wanted to be cognizant that the clinicians were going to be receiving a lot more alerts. And so we were paying a lot of attention to what alerts they would get, when they would get it, what they would look like, to try to make that transition as smooth as possible. Next slide. So I'm going to pause here for response, and I hope that you'll participate. How would you rate your organization's current ability to adjust medication alert thresholds based upon those patient-specific risk factors that I just identified? Medications, lab results, problems. Would you rate excellent, good, fair, poor? So these, oh, great. So it sounds like overall, majority of you say you do a good job. Actually, nobody has said an excellent job. Maybe that's why you're here to listen to this talk to get some ideas. And then some of you maybe started from where we started, doing a poor job. So let's keep going here. So in terms of our goals specific to that clinical decision support, again, we really wanted to use patient-specific metrics. We wanted to do this to reduce alert fatigue. We thought that if we could be very specific with those patient alerts, we would hopefully reduce the amount, and we really wanted those providers to pay attention to those alerts. And we knew that if there's too many alerts, you get fatigued and you're not going to pay attention to those. And having too many is just as much as having none at all. We wanted to provide a risk assessment. We wanted to alert not just for any alert possible, but to try to improve the predictive value. So really alert only when it is the highest risk or the interaction is significant. Really, again, looking at those patient-specific factors, but doing a risk analysis. And then we really only wanted to alert a provider if there is something actionable that they could do, either canceling the order, modifying the order. And we wanted to make that as easy as possible. We wanted that alert, that pop-up, to immediately take them to an area that they could make a change. And we certainly didn't want there to be any hard stops, a hard stop being where something pops up and you can't get out of it. So we really were trying to look at all those factors. Really, to synthesize it, we wanted the right medication alert to happen at the right time for the right provider. Next slide. So there's a lot of considerations we had in how we were going to accomplish this. And the first thing we did was to try to understand how complex the build would be. So we reviewed and we started researching drug and prescription information, and we quickly realized this is a vast area of knowledge, and it is ever changing. And we realized that that was probably not something we were going to be able to do ourselves. So we pretty quickly started looking for a strategic partner to help us be able to review and research that drug information and stay up to date, because this is information that is constantly flowing. We also knew that this was going to be a project that required quite a bit of maintenance. And so we got an estimate that the average hospital spends 60 hours per month of ongoing maintenance on custom clinical support tools. And that's just maintenance. That's proactive maintenance. That's just maintenance, and not even when a clinician reports a problem with an alert, or if there's a patient safety issue, because that can potentially double the amount of maintenance time. And we were not only concerned with the cost of a clinical hospital pharmacist or a pharmacy analyst. The cost alone could be upwards of $30,000 to $50,000 a year for those roles. But just the ability to hire those roles is quite difficult. So just the availability of resources in addition to that cost. So that's really, again, why we knew we needed a strategic partner. And we did a prioritization of our warnings to try to understand what was our current workflow, what were our current resources, and what were the needs of our system. And so if we go to the next slide, I'll show you the alerts that we really focused on were the hyperkalemia, which is a real patient safety issue, QT prolongation, which was our highest alert and quite complex. Also, outpatient opioid risk assessment to stay in compliance with regulatory organizations, and then nephrotoxicity, again, an area that we really felt could be useful. Some areas that we analyzed but decided that we weren't going to implement immediately, but we would have been in the space of pharmacogenomics. And I think that's something that's an evolving field. And I think it's something that we're paying attention to, but it's not something that we're currently practicing a great deal on right now. And so again, not trying to overwhelm our providers with a lot of alerts and maybe gradually introducing more, we decided to stick with just these 4 for our initial phase. We were already, we thought, doing a pretty good job monitoring bleeding risk, so we didn't enable a warning like that. We had a hematology pharmacist that was already monitoring neutropenia, and we felt like our current alerting was adequate with therapeutic drug monitoring and anticoagulant interactions with epidurals. So these are the 4 that we wanted to focus on. And I thought I would try to go through some of these with you. Next slide. So in terms of optimization process, our team looked like this. We had a pharmacy architect who was the true lead and owner of the project. We then had significant involvement from our third-party vendor, First Data Bank, FTV. We had an orders team architect who helped with a lot of our testing. We had a clinical applications leader, an interface architect. Initially, we needed to involve EHR vendor, and we had a lab architect who helped us with the testing when lab interface was necessary. And then only would we invite other specialists when we were reviewing an alert that was pertinent to their field. We were able to accomplish this in 14 weeks, doing this by doing a single build session, 1 hour a week for 14 weeks. So a total of 14 hours, we were able to accomplish these enhancements. The meetings were really working meetings. So discussions were had and build was started immediately. So I think highly efficient. We accomplished quite a bit in a short period of time. Next slide. So to give you an example of the build, how it would go, this is the hyperkalemia alert. When a clinician enters that medication order, an order for any medication, a query is sent. And to see, looking back 3 days, if there are any potassium readings greater than 5. If there are not, no alert displays. But if a potassium level is greater than 5, again, that CDS query is sent. There's a look back or an analysis for a drug-drug interaction or a single drug that could potentially cause or exacerbate hyperkalemia. And if so, that alert displays. So let's take a look at the alert. So our legacy alert would look something like this. And I would say it was overall good. It was actionable. So it checked that box and the fact that you could accept the alert or not. A lab value was present at the time of ordering. So that's important to give the information to the provider at the right time. And there was an option of why you would be overriding the alert, but only one was present. So let's look at what the enhanced version looked like. So this targeted medication warning, I'm going to point out the things that I think were an enhancement. So one, a clear label. I know that sounds simple, but it's always nice to clearly see at first glance, why are you getting this alert? Particularly if you're getting quite a lot of alerts, it's nice to call attention to that. You see the med warning, so you can see the actual medications that the patient has on their medication list and those potential interactions. We have more actions, so the ability to keep or remove any of the medications, not just the medication that you're ordering. And we've included more override options to collect more information of why the provider may be overriding the alert or not. And this is also a lot of feedback from our providers in our organization is that they feel uncomfortable when they override an alert, but there's not the reason specific to their instance of why they're overriding it. So we try to incorporate all the possible reasons that they could be overriding the alert. Next slide. So again, this was our number one alert, and this is the QT prolongation. And so looking at this targeted medication warning. So not only is it doing a check to see if there is a potential risk for QT prolongation just based on the drugs, it's actually looking at patient-specific risk factors, and a risk score is calculated based upon those factors there. So the patient's age, the sex of the patient, whether they're on a loop diuretic, whether their potassium is elevated, if they have an EKG on file discretely looking at that QT number, and then other problems that are ongoing, that are on their problem list. And so the ability to keep or remove that drug, and again, those acknowledgement reasons. And we'll talk about this in a bit, but this it calculates a score, and this score can be used as a threshold of which the alert is fired. And so as we analyze how often the alert is firing, or if there are adverse events, you have the ability to raise or lower that risk score of which the alert would fire. Next slide. So this is the opioid alert, and this is to assist the clinicians in following CDC guidelines for prescribing opioids for chronic pain. This is our old alert, and it's calculating an oral morphine equivalent, or MME, milligrams of morphine equivalents per day, and highlighting whether they're at moderate or severe risk. This is what's required by the CDC. And some recommendations to consider removing the medication. But again, next slide, let's look at the enhanced alert. Again, a clear label. And what I like here is a table that is clearly showing the medications that the patient's being prescribed. And it's not just opioids, but it's any sedating medication. Sedating medication or benzodiazepines, because again, when we're prescribing and assessing somebody's risk, it's not just the opioids, but it could be the interaction with other sedating medications that could lead to the patient, suffering from slow breathing and hypoxia. And then again, more override options at the request of physicians to identify the reason that they feel like it would be safe to continue the order as prescribed. Next slide. Great. And then nephrotoxicity. Calling attention to a medication that if the patient's creatinine clearance is not adequate, could cause either nephrotoxicity or increased concentration of that medication. This is our old alert. It is nice that it shows what the creatinine values are. It gives the ability for medication adjusting and override options. But one of the things that it lacked is, next slide, the ability to review the previous 3 days of creatinines, and not just to look for an elevated creatinine, but to see if that creatinine is rising, because acute kidney injury is quite prevalent in the acute setting, and can underestimate the patient's filtration rate, or eGFR. And so looking at that rise in serum creatinine, we think is really important for patient safety. And being able to show all the medications in the alert of the potential interaction. Next slide. So what these alerts and our project really helped us do was to provide adequate clinical decision support to the provider to promote patient safety. And one of the ways that this gets measured is in Leapfrog computer physician order entry testing. And so this is an evaluation tool where Leapfrog is asking for at least 85% of inpatient meds to be ordered via computer system that includes decision support software. And we're a 2-hospital healthcare system. And so I'm showing you in pink, our downtown hospital, and in the blue, purple, our North Naples hospital. And you will see a gap in 2020, 2021. This was during COVID, and so it was not a reporting period. But what I'll highlight to you is we were not maximizing our score in our legacy environment because we had turned off so many of those medication warnings. But with the work that we did in our reporting in 2022 and 2023, we were able to significantly improve our Leapfrog scores from on average from 63 to 80%. And by doing so, maximize the points that we could score with CPOE testing. This is not necessarily out of 100. And we're due to do our testing, I think later this week for our 2024 score. Next slide. So again, we'll pause here. How often does your organization review and adjust medication alerts for relevance and effectiveness? So we're going to transition here from this initial project to ongoing maintenance. And we really wanted to maintain the gains that we made, but also make alerts more patient specific and sensitive, and reduce the alert fatigue to the provider. So does your organization have a review process? And if so, what does it look like? Okay. So it looks like a quarter are not doing a review process. Maybe I can convince you of all the benefits of doing so and give you some strategies to do so. And then it looks about half of you guys are doing it on about a quarterly basis. And then I think that's supposed to be monthly, somewhere between monthly and quarterly. And that's kind of exactly what we decided to do. So we decided that we wanted to do a review process every other month. Next slide for me. So we have a decision support committee that meets bi-monthly, and I always have to look that up. That is every other month. And what we found is that we wanted the composition of that committee to be largely the same people that were present during our build process. But I'm going to call attention to 2 additional players that we really identified needed to be present in our decision making, and that was a manager from compliance and somebody from our risk team, because really all of these decisions we face are a balance of reducing alerts to make them more meaningful and to reduce that alert fatigue and burden, with maintaining patient safety and quality, and frankly also to be able to pass various quality scores like Leapfrog. And so it's really a balancing act. And we really found that it's important to have those discussions up front and at the time that you're making the decision, so that everybody involved knows why we're making that decision. And we're really able to have that in a robust way. Again, this was largely led by our pharmacy team, and I can't say enough about how excellent our pharmacy team has been through this. So we have actual pharmacists, and then we have pharmacy analysts, but we know that this is impacting the rest of the clinical team too. So it's really important to have physician involvement and nurse involvement, because all 3 groups, the pharmacists, the nurses, and the physicians, are the ones getting these alerts. So they really should all have a seat at the table. When we do the evaluation process, we're looking for trends, and I'll show you a couple of examples. We're trying to identify issues and then ideally solve them. Like I said, have a discussion, have that working meeting so that everybody can give their input and then ultimately come to a decision. And then if we have multiple changes that we want to make, be able to prioritize as an organization or at the department level, what's most important, what needs to be fixed or modified first. So let's take a look at some of the examples. Next slide. At first we'll talk about how we do that. So each week, an upload of the alerts that fire in our EHR are automatically transferred to FDB, that third party. And we do that because FDB is a product alert space that enables us to easily summarize that information. So we can do an ongoing review and breakdown of the raw data, but also look at it graphically to assess trends. And one of the things that comes up very frequently is how do we compare to other organizations? That's a key question for us. And so the ability in that space to compare ourselves is extremely helpful. And we're largely looking at four things. Who is the alert firing to? Is that person appropriate to get that alert? How often are they getting the alert? Is this a high frequency alert? And we care actually about two things. We care about the alerts that fire most often, but we also, we still worry about what I call the paper cuts. So even a alert that doesn't fire that often, if it is really annoying or it's one of these alerts that you really don't think is appropriate, I consider it an insult. And I feel like it's something that resonates, and you kind of take it home at night and you're kind of really frustrated. Why did that alert happen? Why did it interrupt the flow of me taking care of the patient? What actions were taken? What did the clinician do when that alert fired? And then what was the feedback from the providers of that alert? And we can get some of that feedback in the reason for override. But we're also developing a culture around our alerts, not just our medication alerts, but also our best practice alerts. We're really trying to solicit provider input. So again, we can tackle the high frequency alert, but also just the ones that are so annoying that they come to me about, or other of my IT colleagues, to say, this happened here and I didn't think that it fired appropriately. That feedback has been extremely helpful for us to know, really to prioritize what to fix first. Next slide. So this is, I just want to highlight here the raw data that we can look at. And we can sort by this to see who is it firing to a pharmacist, to an ordering clinician, to a nurse. We can look at what kind of drug class or what two drugs were the interaction to see if that's something that's very frequent or not so much. We can look at the severity of the alert. So there's a lot that we can do with this raw data at the granular level. It's sometimes where we start, but it's most likely where we finish. But we're also able to filter this in some other ways. So let's take a look at that. One of the first filters that we almost always look at is what alerts are being overridden. And so we'll be able to grab the top 10 alerts that were overridden and be able to dive deeper into this. So, the top alerts for us are the overridden alerts are the opioid analgesics, providing a duplicate alert. So that's if more than one opioid is being ordered, alert is fired. But what this is telling us is, because it is so frequently overridden, that the clinicians are saying to us that it's appropriate for this patient to have more than one opioid on their chart, maybe one standing and one PRN, one for moderate pain, one for severe pain. And I'll show you how we deal with that in a second. If you can go back one, sorry. And then we can look to see if it's being overridden. Maybe we need to change our settings. So perhaps we need to adjust how the alerts are firing based on the severity. Do we want to see all severity classes, minor, moderate, or major? Or if it's alerting too much, do we need to change the settings to maybe only show moderate and major in this category? And then there's additionally, you can sort or filter by established known drug interactions or more of the suspected interactions. So you can do this on select different settings. And just because an alert is overridden doesn't necessarily mean that the alert is wrong or the information provided to the clinician is inaccurate or inappropriate. It may be that the clinicians don't know how to interact with the alert. And so being able to look specifically at the alert and when it's firing, again, it may be at that granular level, has helped us to say, hey, we need to educate the providers, the clinicians on the specific alert, because even though they're overriding it, maybe they shouldn't be. So it's giving us a lot of useful information to either tailor the alerts or tailor our education. Next slide. And so if we just look at overall the warnings that are firing and then looking by class, we identified really that the duplicate alerts, the duplicate therapies was what we would say would be the lowest hanging fruit. That was the majority of the alerts. And as we looked into it, again, we had a lot of orders that we did feel like were appropriate to order a pain medication for moderate pain and another pain medication for severe pain. So we knew that we needed to adjust the number of medications. Next slide. And so again, graphically, how we can look at this is warnings per order. And, one of the things that we're obviously very proud about is a pretty significant reduction in warnings per order. And we did this, we had our initial reduction in warnings per order by doing the following two things. So in August, we increased the duplicate allowance of non-opioid analgesics and opioid analgesics from 0 to 1. And so what that meant is before we made this change, a clinician would get a warning if a single duplicate would be occurring with this new order. And we've modified it from 0 to 1 so that they don't get the alert ordering the second medication, they get the alert on the third medication. And this is something we're continuing to evaluate, and I'll show you again in a later slide. But that alone made a significant difference. As well as turning on a drug disease never alert. And so the never alert, I just want to call attention to, is a list of medications that was developed with FDB and Kaiser Permanente, I think in a very robust way, as they surveyed clinicians and pharmacists of alerts that they felt were low value and really should never be appearing to the clinician when they were ordering a medication, either because the alert was rare or insignificant. And Kaiser Permanente was able to, using this list, reduce the alerts from 32,000 per month to just over 1,000. So like a 96, 97% reduction in their alerts per month by disabling the alerts that they felt should never fire to providers. And we were able to utilize that list that they created to help us. And we, using that to leverage their information, we were able to significantly reduce the alerts in our space. Not all the changes that we make have that significant impact, but we're continuing to do some work. And I'll show you in the next slide what we've been working on most recently. So we decided that increasing the duplicate alert from 0 to 1 was great, but we wanted to do that further. So we increased the opioid analgesics from 1 to 2. And then we also looked at a new class, the class of beta blockers, because again, it would be quite frequent for a patient to have a standing beta blocker order and a PRN order. And we felt like more often than not, that was appropriate. So we made that change where the arrow is, and why I think you see some of the variation early on is I didn't allude to, is being in Southwest Florida, we have a seasonal population. Patients from cold weather states frequently come down. We call them snowbirds to spend the winter in a warmer climate. So our volume of patients significantly increases in the months of January, February, and March, and it is lowest in the summer months, July and August. So we're in this graph, we're looking at alerts only, not alerts per order, and so that's why I think you see some of that increase and start to see the decrease in the summer months. But you see a greater than 50% alert reduction just by changing change in the opioid analgesics and the beta blockers up from 1 duplicate amount. And then we made another change by modifying the PRN, or as needed reason, with less success, but some additional benefit. Next slide. So again, not only did we reduce the amount of alerts, but we reduced the amount of alerts that were overridden. And I just wanted to show you, we often look at this in multiple different ways to try to identify, to make sure that we're not only reducing the alerts, but we're trying to increase the acceptance of that alerts. Next slide. So again, if we go back to looking at warnings per order, we've seen a trend towards less alerts, and we were doing the monitoring, and we were expecting a great improvement when we made those changes, because we were seeing a decrease in those alerts, but we were kind of surprised to see this uptick of warnings per order. And we did see a decrease in the alerts that I just showed you, but we wanted to try to understand, why are we seeing more? And so I'm trying to highlight the importance of this monitoring, because what it was able to do is to help us identify what was going on. Next slide. So we're very grateful that FDB is constantly looking at drug-drug interactions. And they are constantly introducing new warnings that they feel are appropriate. But in this instance, they introduced a new alert. This was for medication interaction of glucagon and anticholinergics. And what we found is, when we took that enhancement, it immediately became our #1 medication warning. And by looking at this on an ongoing basis, we were actually able to identify this very quickly. Next slide. And so we were able to see that it was, again, not only was it firing, but it was being overridden almost all the time. And then using other analytic tools like Slicer Dicer, we quickly wanted to understand, well, why is it firing, and is it clinically significant? And so one of the things that we noticed, these are 4 different environments that it was being ordered. It was being ordered, glucagon is ordered very frequently in our institution, because it's part of an order set with insulin. Anybody who's being ordered insulin also has glucagon, which is only used in the event of a hypoglycemic event. So even though it was ordered 168 times a day, it was administered less than once a day. And we felt like that order the warning didn't justify the means, because it was being administered so infrequently, and this was really a rescue medication. We felt like this was most appropriate to disable the alert, and that's what we did. And if we were to go back to the graph, you see that once we disabled that, we continue to see the trend decreasing of warnings per order. Next slide. So we're really proud of the work we've done so far, but we also understand that there's much work left to be done. And so these are the categories that we're really trying to focus on now, is to look at the drug-drug interactions, and to see, to dive in our instance, if there's alerts that we feel like we could suppress to make the rest more meaningful, to call more attention to the ones that we think are most meaningful. To look at drug allergy sensitivity, and whether we want all drug allergy alerts to fire, or really only the most sensitive ones. So that's an area we're going to look at. Also, being on our new version of our EHR, our problem list is more robust. So we feel like we can now focus more on drug disease interactions. And lastly, we really want to improve that override reasons to capture more feedback, so we can make more feedback specific to the users. Next slide. So in summary, fewer alerts would probably be best for providers. If you polled them, they'd probably say they want less, but patient-specific alerts are best for quality, for improving patient care and keeping patients safe. So really what we need to do is continuously monitor, improve those alerts for an optimal balance of patient safety and quality, and provider wellness. And with that, I'm going to say thank you, and I'll ask Gail if she wants to give me any questions. I'm also going to give you my contact information. If there's anything you want to reach out to me for clarification or questions, that's my contact information there. And then Anna Dover from FDB would also be happy to answer any questions that you may have about their product.
Wow. David, thanks so much for this really helpful presentation. A lot of fabulous information about this journey that you've been on and a tremendous amount of work. But really a key takeaway that I've heard from you is the intensity of the ongoing nature of your work. Yes, there was a start, but it is really longitudinally, a continuous work in progress, so to speak. So we do have some questions. Thanks so much. We're going to jump right in. We have about 10 minutes to engage in questions. Please, for those of you with us in the audience, put your questions into the Q&A tab and we will be happy to address them. The first one comes from Lacey Turnez from Freighter Health, who asked the question, if labs are drawn at an external facility but abstracted within your health system, will those be incorporated in the warning, or does it need to be a lab drawn within your health system?
I believe that it can be any lab order that is interfaced. So we currently have an interface with one of two reference labs, soon to be both of the major reference labs in our area. So as long as it is discreetly available, I do believe it fires. But anything that would be scanned into the system, unfortunately, is not able to provide that medication warning.
Okay, thank you for that, David. And perhaps that's an integration issue or opportunity for your IT enabling colleagues to address. I love that reference that you made to IT enabled body of work as compared to IT led, which I know many health systems are trying to achieve the same. We have another question from Lourdes Rojas from Baptist Health South. First of all, great talk. Can you please share how warnings per order was calculated, specifically in the raw data file? Can you share a little bit more about how the various columns were used to calculate the warnings per order?
I hope
That's
I'm not
a pretty detailed question here.
I hope I'm not going to oversimplify it because I've not delved into this deeply, but I do believe it is simply calculating how many orders are being placed and then dividing that by how many warnings are firing to the clinician when placing that order. And I'm always astounded it is so high. I mean, basically almost, or 1 out of 2 orders, you're getting some sort of alert. I wonder if I need some clarification so I don't overly simplify that question. I apologize if I am.
Well, we can ask Decretia to take Lourdes off mute. If Lourdes is still with us, can she ask the question a little bit more specifically live?
Hi, good afternoon. Oh.
Go ahead, Lourdes. Thank you.
No problem. I can reach out via email. I think you mentioned that you had the first data bank folks on here.
Yeah.
Use Lights On, like from Cerner, and they have some similar visualization techniques, and we get some reports from there. And so when you showed your raw data file, it looks similar but not the same as ours. And so maybe I could follow up with an email because
so I think I can clarify that one for you.
Yeah.
So the raw data from Epic in our instance is flowing to FDB, and we're using their software to calculate that alerts per warning alerts per order. So it is using the Epic raw data, but they're putting it in a format that is more usable. And another thing to call out is that in that space, we're able to review the information and then make changes real time that go back to our system when we take that enhancement, which is typically on a weekly basis.
Thank
Okay,
you.
thank you.
Thank you, Lords. Thank you, David.
You can get a lot of that information in Epic, but we found that it's more graphically pleasing and more it's been easier to analyze that information and make changes in that alert space.
Well, David, we're all going to be rooting for you with your review for your Leapfrog outcome results for 2024. It certainly seems like you're poised for demonstrating improvement. What a major change from your alerts of the past to the alerts of the future. Obviously, they were graphically so much more relevant and impactful, I imagine, with your clinician community. But maybe you could speak a little bit about how do you recruit and retain all the members of your decision support committee, which is really a vital lifeblood for this body of work?
Yeah, so I mean, I think we're very lucky that we have some very dedicated team members that are very much interested in this project. Our organization is very focused on wellness, and I think as we've called attention to why this project is important, I think that our team members have prioritized it appropriately. And I think the more progress we make, it's becoming easier and easier to get that feedback, and everybody feels more willing to share, especially when they share and then a change is made. They feel like progress is happening, and so good is getting great. And so it's been a rolling process that has been helpful.
Well, that's a credit to your leadership and the process that you've put in place, because the way to demonstrate success is really by listening to people that are on your committee and really taking action. So thanks for that tip as well. David, maybe going back to a little bit about what are your next steps. How do you even look to prioritize your next bodies of work? You mentioned 4 areas towards the end of our discussion, but do you also expect to expand your clinical areas? You know, you started out in 4 clinical areas, opioids and so on. Do you expect to expand that as well?
Yeah, I think so. I alluded a little bit about the pharmacogenomics. I think that's going to be a piece for us that we'll want to utilize shortly, and maybe not in the short term, but maybe on the medium term, because I think we're seeing a lot more information from patients that have performed genomic testing, and so now we're at the point where I think we're starting to reach that critical mass where having those alerts would be useful. And I think, providers are more familiar with that and maybe more ready to have that alerting.
Thank you for that. And, are you getting pats on the back from your clinician colleagues as you now interact with them? Are you feeling that positive energy in terms of the work that you've been committed to?
I will say yes, and it only takes 1 or 2 to feel really good. But in this work, the lack of negative feedback is often our best feedback, and I definitely feel that there's been less of the complaints, less of the negative feedback of getting too many alerts and alerts that aren't meaningful. So I take that as a pat on the back as well.
As you should. David, we are just about out of time today, but I want to thank you most sincerely on behalf of our members here at Scottsdale Institute for sharing this journey. We'd love to have you back and hear about your continued outcome work. Very helpful to share this with our audience. And please, our audience members, thank you for being with us today. Take a moment, please, to answer a brief survey. It will only take a minute. It will help us continue to bring great content to you in the future. So David and all of our participants today, thanks again for being with us, and have a great rest of your day. Bye-bye now.